That day in the series we are running, we are discussing, we are looking at headache and other headache and associated disorders of neuro ophthalmic origin, and this is the part 2 of it. Last week we looked at the part 1, so if you've not subscribed, please do well to subscribe, do well to like, do well to comment, and do well to share the video. I'm just going to give you a few minutes so that if you are just joining us, you can quickly go and subscribe, you can quickly comment, you can quickly like the video so that it helps us in producing more and giving out more to the society. And last week we began by introducing the concept. Last week we began by introducing the concept of headaches and neuro and associated disorders of neuro-ophthalmic origin. So today I want us to look at a continuation of what we've been doing since last week. So last week we introduced the concept, like I said earlier. Today we are going to take it a step further, and then it's going to be a series of about 4 to 5 classes, and I'll be making sure I break them down into simpler sections so that every one of us can understand it, know it, and learn how to apply it in the clinical setting. So last week we began by introducing, we said that the term headache is defined as any pain in any part of the head. So whenever we are trying to describe headache, we are looking at pain in any part of the head. It could be throbbing, whatever it is, but if there is a pain, we target headache. And we also say that it's one of the most frequent health complaints encountered in the clinic, that most times patients will come to the clinic, sometimes 6 out of 10 are complaining of headache. So it is very, very frequent, and every clinician should and understand the concept of headache and know how to go about it. We also say that 90% or more of individuals have experienced at least one form of headache. That 90% of individuals have at least experienced one form. There are several forms of headache, and 90% have experienced. And even those who have not experienced are eventually going to experience it one way or the other in their lifetime. So it is a very, very critical topic and important topic as well. We also looked at the trigeminal nerve, which richly innervates the eye, and this is why the pain that comes with headache, the pain around the eyes that comes with headache, because of the rich innervation of the trigeminal nerve of to the eyes. We also looked at that the International Headache Society has published about 176 different types of headaches. That 176 different types of headache have been published by the International Headache Society. This tells you a lot. This tells us that a lot of things, a whole lot is going on in research, a whole lot is going on in trying to demystify this concept of headache. So a whole lot of guys, top men out there, they are doing researches here and there, classifying just to better humanity, and we have to call them their flowers and kudos to them. And also, due to the complex nature of classifying headaches, it is important that a thorough case history and clinical evaluation is made, and this can only suffice for about 30% of the cases. So that we talked about this last week, that because headaches are complex, headaches are they are not straightforward as they appear. So a thorough case history must be done. A thorough case history is done to it, and the case history can give us pointers to what is going on. Are we together? So we talked about this last week, and then last week we began to introduce the whole concept again, the important clues and all that. So today, being the part 2 of headache and associated disorders, we'll be looking at important clues. What are the important clues we are to look out? And then we'll call it a day today. We know it's a series, and I want to break it down into simpler forms, so that we can go home with something at the end of the day. And then after the whole series, I'll be publishing the slide I'm using. I prepared the slide, I did a lot of research on them, sourcing from different sources, renowned men who have done great work in this field. So I will not claim to be the founder or the discoverer of this knowledge I'm sharing. I got them from textbooks, from articles, from journals, from videos of men who have done great strides. So we are just trying to fit in the gap for, because they have done a whole lot of things. Are we together? So today we are looking at important clues. What are the important clues we are to look out during the case history? What are the important clues to look out for? And these clues, they are so important that if you have them at the tips of your finger, they can just lead you straight to the type of headache you are dealing with. If you understand these clues, if you know them, and if you know how to unravel them, they can lead you straight ahead to whatever it is you are looking for. So the important clues are: one, the frequency of this headache. How often is it happening? Secondly, the location of the headache. Where is it located? It can give you a very, very important clue on the type of headache you are dealing with. Thirdly, the duration of the episodes. It is very, very important. Fourthly, the intensity of the pain. Fifthly, the usual cause, the cause it follows. Then the sixth clue is triggering factors. What are the factors that trigger it? What are the things that lead to the headache? It is so important that it can lead you to wherever you want to, wherever the headache is pointing to, and tell you the origin of the headache. And then finally, the family history. The family history is so, so important. It has a way of telling you what we are dealing with. So we are going to be looking at each and every one of these, and then trying to understand them, and then help, in other words, trying to look at how these things are going to be pointing us to where we want to go to. Remember, I said again, the frequency, the location, the duration of episodes, intensity of pain, usual cause, triggering factors, and then the family history. So let's begin. So we are going to be looking at, first of all, the frequency of the headache. What does the frequency of the headache have to say to us? What pointers does it show to us? First of all, let us look at these few facts about the frequency of the headache. Throbbing headaches that occur seldomly or several times in a year is associated with autonomic symptoms and are signs of migraine. Throbbing headaches that occur once in a while or several times in a year and are associated with autonomic symptoms such as vomiting, those symptoms is sweating. These are what we call autonomic signs and symptoms, are pointers to migraine. So when your patient comes to the clinic and then he tells you that he has headache few times or several times in a year, and then it comes with autonomic signs and symptoms, likely it is pointing to migraine headache. And I want to also give a disclaimer. We are not saying this that it can be hook, line, and sinker, that every time you see this sign, it must be this. No. What I'm trying to say is that these are pointers, they are indicators that if you see this, okay, you can begin to suspect this. So when a patient complains of throbbing headache that occurs few times or more in a year and associated with autonomic signs and symptoms, our pointer is migraine. Headaches of specific period occurring in episodes each day are pointers to cluster headache. So in cluster headache, you find out that they happen within specific periods. They occur within specific period and in episodes. That is, it comes again and again and again and again. So it is a pointer to cluster headache. And the frequent attacks of head and facial pain, usually 20 times daily, are caused by chronic paroxysmal hemicrania. So chronic paroxysmal hemicrania are frequent attacks or pain that usually happen 20 times daily. So the criteria is that it should happen at least 20 times daily for it to be categorized as chronic paroxysmal hemicrania. Are we together? Then chronic headaches presenting daily are pointers to tension headache or analgesic induced pain syndrome. So when you have chronic headache, chronic means that it is severe, it is beyond normal, and is presenting daily. So it is a pointer that probably what is going on is a tension headache or analgesic induced pain syndrome. So what this means that there are when analgesia that are given to reduce pain, but then they rebound and begin to cause pain. Likely this is a case of tension headache. So this is all it is to the frequency. So when you understand the frequency of this, it helps to guide you on the kind of headache we are looking at. Then the location of the headache is also very, very important. The location of the headache is also important, and this is the next important clue we want to look at. Now, when we mean by location, when we mean absolutely unilateral, when it is absolutely unilateral, that it is one-sided, it is likely to be a cluster headache. Cluster headache, most times, if not all times, they are unilateral. They are absolutely unilateral. And then also migraine headache also are unilateral, which means they are one-sided. They are one-sided. That one what we mean by unilateral. And also retrobulbar or retroorbital are cases of cluster syndromes too. Cluster syndromes can also come as retrobulbar or retroorbital. And then pain projecting into the occipital and parietal region are signs of cervical neuralgia. So when you see pain projecting, they are projecting from the projecting into the occipital and then parietal region. It is a sign of cervical neuralgia. And then holocephalic, if it is holocephalic, you find this in tension or analgesic induced headache. So when you see tension analgesic induced headache, they are usually holocephalic in origin. And also the duration of the headache is also very, very important. So let's quickly look at the duration of this headache. Now, short-lasting unilateral headache with conjunctival injection. When the headache is lasting for few seconds, when headache lasts for a few seconds, is a sign of what we call the SUNCT, SUNCT, which stands for short-lasting unilateral neuralgiform headache with conjunctival tearing and injection. So this kind of headache usually lasts for few seconds. So you find out that there is headache and then the conjunctiva is injected and tears are coming out. So this kind of headache, it lasts for few seconds. So this duration can tell you that this can be SUNCT headache we are looking at, which is SUNCT is short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. Is a kind of headache. And then headache lasting for 5 to 30 minutes could be a pointer to paroxysmal hemicrania. So headache that lasts for about 5 to 30 minutes and then they stop are pointers to paroxysmal hemicrania. Headaches lasting from 20 minutes to about 2 hours. So the patient tells you that the headache is lasting for about 20 minutes to 2 hours. Is also a pointer to cluster headache. Cluster headaches last between 20 to 2 hours. Then for migraine headaches, they can last for about 4 hours to 72 hours. Migraine headaches can last for about 4 hours to 72 hours. So migraine headache is a very terrible kind of headache. And in our next class, to be our first session, we'll be looking at migraine headache, the pathophysiology, the origin, the etiology, and what all that it's or everything concerning migraine headache, and then the treatment plan. Also, tension headache, analgesic induced headache, temporal arthritis, and pseudotumor cerebri are constant and persistent. So when you see a headache that is constant and persistent, it could be indicative of tension headache, it could be indicative of analgesic induced headache, it could be indicative of temporal arthritis, and it could also be indicative of pseudotumor cerebri. So a headache that is chronic and persistent, these are the clues you are to look at. So that is that for the frequency and duration. Let us look at the intensity of headaches. So the intensity is also another clue we want to look at. But then the challenge with intensity is that this is subjective. What do I mean by that is that sometimes it is based on the patient's response. There are patients who have a higher threshold for pain. So they might not be able to, they can be able to withstand so much pain that even though the pain is much, because they can withstand it, they will not be effective in grading the intensity. And there are also patients who little pain they exaggerate it. So the pain might be mild, but because they have a low threshold for pain, they are going to exaggerate the intensity of the pain. But either ways, we are also going to classify headaches or head intensity is an important clue in classifying or pointing us to the type of headache we are dealing with. So intensity of the pain is usually subjective and difficult to quantify. But migraine headache, paroxysmal headache, and cluster headache are usually the most intense. These headaches are usually the most intense that the patient most time cannot bear it. Some of them can even go blank out. Some of them might even have transient vision loss. So migraine headache, paroxysmal headache, and cluster headache, this kind of headache, they are the most intense. And such patients, most times, they find it difficult trying to live with it. The moderate headaches are seen in cases of temporal arthritis. So people with temporal arthritis, they tell you that they have headache, but then it is moderate. It is a type of headache that they can maybe go about with their daily activities, but they know that something is wrong. And then mild to moderate headaches are experienced in cases of chronic tension headache. So mild to moderate are experienced in cases of chronic tension headache. But remember, like I said earlier, that this is subjective. So the patient might not be able to effectively quantify the intensity of this headache. And then alternating cases of mild headaches are experienced in venous sinus thrombosis. So when the headache is alternating, it comes and it goes, it comes and it goes. So it could be indicative of venous sinus thrombosis. We are going to look at what venous sinus thrombosis is in subsequent classes. So just relax. We are going to take it bit by bit. And then another important clue we are to look at is the cause of pain, the paths through which the pain follows. Are we together? So the first pointer I want us to note is that rapid and intensified pains mimicking stroke. So rapid and a headache that is rapid, and it's not just rapid, but as it's progressing, it is increasing in intensity. It could be a sign of intracranial hemorrhage. Headache that is rapid and intensified could be signs of intracranial hemorrhage. Headache emanating within few minutes could be indicative of cluster headache and chronic paroxysmal hemicrania. So headaches that are emanating, just the patient is fine now, and within few minutes, headache is there. So it could be a pointer to that. Also, migraine pain reaches its peak between 15 minutes to 2 hours. So people who have migraine usually tell you that it becomes severe after 15 minutes or after 1 hour, but migraine pain is usually progressive, and then it reaches its peak and then it begins to diminish. Are we together? The pain noticed in venous sinus thrombosis is usually experienced at night and morning hours. So a patient tells you that at night I feel headache, and also in morning hours, it could be indicative of venous sinus thrombosis, and it's usually exacerbated by sleeping horizontally and partially relieved when in an erect position. So when the patient tells that when I sleep horizontally, it increases, it progresses more, it's also indicative of venous sinus thrombosis, and there's usually a mild relief when the patient is in an erect position after waking up. Also, a progressive increase of head pain in a patient with no history of headache could be indicative of cerebrospinal fluid obstruction or elevated intracranial pressure. So a progressive and increase in the pain. There is no history of pain, there is no history of headache. Likely what you are dealing with could be, I'm not saying it's a must, but it could be indicative of cerebrospinal fluid obstruction, or the intracranial pressure is elevated. And then during your ophthalmoscopy, absence of spontaneous venous pulsation in a patient who it used to be present before could also be indicative of elevated intracranial pressure. And also, let us look at the triggering factors, and then we'll look at the family history, and we'll call it a day for today. So what are those things that trigger headaches? So during case history, you can begin to ask the patient, what triggered this headache? The patient could tell you that, okay, it was after I was exposed to a particular substance, or it could be after I went to this particular place and came back, and then the headache came. So the triggering factors are also pointers to what type of headache we are dealing with. Now, in case of migraine has a whole lot of triggering factors, and let's highlight them and just talk a little bit on them. So one of the triggers of migraine is a disruption in the circadian rhythm. We all know that circadian rhythm is responsible for the sleep-wake pattern. So you see this in patients who have jet lag, maybe patients who are traveling from one time zone to another, probably from USA to Nigeria. Because of the difference in the time zone and the circadian rhythm is disrupted, it can result to migraine. So people who travel from different time zones can also come down with migraine. It can be a trigger to migraine because the circadian rhythm is disrupted, and the circadian rhythm is responsible for the sleeping and waking pattern. So that is why you find out that people who travel from different time zones, they find it difficult trying to adjust to, they can be awake while others are sleeping, and they are sleeping while others are awake. So their body is trying to adjust to the difference in time zone, and then they can even come down with migraine headache. So one of the triggers of migraine headache is a disruption in the circadian rhythm seen in jet lag. Also, alcohol and foods can also instigate or trigger migraine, especially red wine. There are some patients who they complain that every time they take red wine, they come down with migraine. So with migraine headache, it is important that if you suffer from migraine, you know what trigger them, you know what trigger your migraine, and then you avoid it. So food also that are rich with preservatives or nitrates can also cause migraine. For some persons, anytime they eat cheese, anytime they eat all these things they put in shawarma, hot dog, it can also induce migraine. So it is important to note that drinks and some people, even carbonated drinks, can trigger headache and migraine headache. So it is important we note that alcohol and certain kind of food, especially preserved food with a lot of preservatives, can also be triggering factors to migraine. Also, hormonal changes. This is usually seen in women who are having menstruation. Changes in the hormone can trigger migraine. So you find out that for some ladies, every time they are menstruating, it usually comes down with severe headache. So it could be a pointer that the headache being suffered is migraine headache. So hormonal changes can also be a triggering factor to migraine headache. Also, hunger can also trigger migraine. People who skip meals, so you can skip meals over time and then your glucose level is down, it can induce migraine. Also, another trigger to migraine is stress. When you overwork your body, you overstress your body, it can trigger migraine. So for some persons, they usually come down with migraine when they work over time. When they stretch their body beyond normal limit, it can result to migraine headache. Another trigger to migraine is sudden climate change. For people who enter into a sudden climate change, what I mean by this is that maybe they are in a hot weather and then suddenly they go to a place where it is so cold, or from a cold to a very hot climate, it can also induce headache. Research is still going on why it is so, but a sudden change in climate, whether in the same region or you go to another region and then you are exposed to a new climate, it's also a triggering factor to migraine. Also, caffeine withdrawal. People who withdraw from caffeine suddenly it can also induce headache. Another trigger to migraine headache is sensory stimuli. For some people, too bright light, if they are exposed to a light that is too bright for long, it can induce headache. So it could be sensory, it could be auditory, it could be by their smell. For some people, exposure to very loud noise. People who club a lot, you find out that after clubbing, they come down with migraine headache. So exposure to very loud noise, exposure to too bright light can also induce migraine headache. Also, exposure to certain kinds of perfume, certain smells from chemicals, from plants, from environments can also induce migraine. So for some people, what induces their migraine is sensory. Every time they're exposed to either too bright light, a light that is so bright for a particular period of time, they come down with migraine headache. For some persons, it is after they are exposed to loud noise. For people who work in factories, people who work in airports, people who work in noisy places, or people who club a lot, who are always exposed to noisy places, after a while they can come down with headache. Another triggering factor to headache is intense sexual activity. So people who go for marathon sex, they can come down with migraine because the body is induced or is forced to undergo so much stress within a particular period of time. Also, people who take substances to enhance their sexual performance, like Viagra and all the rest, can one of the side effects, or the one of the side effects that they have is that they come down with migraine headache. So there is no point trying to go beyond your capacity. So intense sexual activity can also be a triggering factor to migraine headache. So quickly, let me give a rundown of the triggering factors to migraine headache. The first I talked about is disruption in the circadian rhythm. The second is alcohol and foods. The third is hormonal changes. The fourth is hunger. The fifth is stress. The sixth is sudden climate change. The next is caffeine withdrawal. Then the next is sensory stimuli, that is too bright a light, too loud noise, or particular smells from perfume, chemicals, plants, what have you. And then intense sexual activity. So these are not the only triggering factors, but these are the most common triggering factors of migraine headache. So if you are suffering from migraine, or you have a patient who is suffering from migraine, it is important that during your case history you find out what actually is triggering this headache, and then try as much as possible to help them abstain or withdraw from those triggering factors. So let us look at cluster headache. What are the triggering factors for cluster headache? There are the triggering factors for migraine headache they are sometimes similar to that of cluster headache, but I just want us to note two important triggers to cluster headache, and then we wrap it up there. So one of the first is alcohol. Alcohol can also trigger cluster headache. So there are people who go on spree, they drink, and there are also people who are not even on spree. They're just a bottle is enough for them to have migraine. So it's just for you to know your kind of person, and then withdraw from alcohol. But alcohol can induce cluster headache. Another triggering factor to cluster headache is vasodilators. There are drugs called vasodilators. These drugs are used sometimes in treating high blood pressure. Example of them, I think, is lisinopril. Is an example of a vasodilator. So these drugs, sometimes they usually have side effects of inducing or triggering cluster headache. So in your case history, it's also important to note the drug history of the patient. So if the patient is having a headache, and then you find out that he's on vasodilators, likely what the kind of headache he's having is cluster headache. So he needs to discuss with his general practitioner or a consultant. They know what to do. Maybe they can withdraw the vasodilators, or they always know how to come in and then stop the cluster headache from repeating itself. And then for other types of headaches, there are no known specific triggers for chronic paroxysmal hemicrania and for tension headache. There are no well-known and defined triggering factors. So today it could be this, tomorrow it could be this, it could be another thing. So research is still going on the known triggers for tension headache and chronic paroxysmal hemicrania. No known or that can be identified as triggering factors for chronic paroxysmal hemicrania and tension headache. And then finally, for today's series, which is part 2, is there is usually a positive family history of migraine. People who have migraine, sometimes they tell you that, oh, my cousin has it, my brother has it, my mom has it. So if you, in their case history, you find out that even someone in their family usually have it. So, and if you have migraine, there's a higher probability that anybody related to you by blood is likely to have it. It's just like glaucoma that is hereditary, that if you have glaucoma, we want you to have a routine. We want those related to you by blood to also have a routine test to screen out for glaucoma. So it is with migraine, that people who have migraine also have there's a family history of it. So a good family history is important to let you know the kind of headache we are dealing with. So thank you so much. This is the end of the class for today. So this is part 2 of headache and associated disorders of neuro ophthalmic origin. This is the part 2. Next week I'm going to be introducing the part 3, and next week we are going to go a little bit deeper. Next week is going to be a little bit intense, so don't miss next week for anything. Make sure you like the video, make sure you subscribe, please make sure you comment, and please make sure you share this video. Share it to a professional, share it to a friend, subscribe. This is your own way of supporting this little thing I'm doing. As you do so, I'm sure you remain blessed. So a quick overview, I looked at the important clues to look out for in headache, and then the first thing I looked at was the frequency of the headache. I also looked at the location of the headache, is a pointer. I also looked at the duration of the headache, the intensity of the headache, the cause of pain, the triggering factors, and also the family history. So this is what we're able to look out today. Thank you so much for joining. I've seen a lot of comments. Jennifer, Wogonoha, Zozu Edits. Oh, thank you so much for joining in. Thank you so much for commenting, and I'm sure you've subscribed. If you've not subscribed, please do well to click on the subscribe button, like, comment, and share. I hope to see you next week. Remain blessed, keep making progress, keep studying hard, keep reading, by all means keep progressing. If you cannot, how do they say it now, if you cannot fly, please run. If you cannot run, walk. If you cannot walk, crawl. But by all means, make sure you are not stagnant, and make sure you are making progress. My name is Dr. Wisdom. I hope to see you next week in part 3 of headache and associated disorders of neuro ophthalmic origin. Thank you so much. God bless you.